Okay, good morning. Welcome to Journal Club. So today we are going to talk about reading radiograph of the thoroughbred sales. So the first one that I have over here is the lateral oblique of the fedlock. And if you don't have a checklist, I have provided a checklist for you in the Stifle Radiograph website. You are going to see it, and I will give you the link later on. But basically, I have provided a checklist that will give you everything that you need to know with respect to the reading of radiograph sales. Now we're gonna wait a minute to one doctor who is getting connected because he just had a fall. Well, he's gonna get connected anyway. He just texted me, Dr. De Angel. So let's give it a minute. 1 minute or two. Meanwhile, what I can do is I show you where is the paper. I mean the checklist. So if you come, ooh, okay, good. So we see that. So here, if you go to this web page, which is equinearthritis.info, equinearthritis.info/stifle, you will scroll all the way down and you go here, radiograph reading checklist, and voila, there's your checklist. So if you don't find it, here's a really good, easy way to get it. And if you need me to add anything to it or you find anything to add to it, please don't forget to share it with me. Then this web page, while the other guys load getting the software, this is a really cool web page to show you most of the things that you can find wrong with the Stifle at the sales. And then the same thing exists for fedlock. So you go to the same URL and then you do fedlock, equinearthritis.fedlock. Did you guys know that? ¿Tú sabías? Sí? Okay, good. So, and here you can find most of the things wrong with the fedlock. Good. And how do I get out of here? All right, so I'm trying to get out of here. Oh, here we go. Here, I'm gonna close it. So let's go ahead and start. So this is obviously the fedlock. So in order to read, in order to have a good reading of a radiograph, it is just extremely important that you read the whole radiograph all the way from the top to the bottom, right? So in the fedlock joint, it is very important to start right here and you go from the cannon bone all the way to the condyle, right? And then you read both condyles. Then you go all the way to the cannon bone. Then once you're done with the cannon bone, don't forget the spleen bone because you're gonna find some fragments or fractures over here. Then you go to the sesamoid, in this case, the lateral sesamoid. Then you go to the other sesamoid. Then you go to the P1, and then you go to the dorsal surface of P1. And let's get Dr. De Angel in. Good. All right. Doctor, can you hear me? I hope you can hear me. Good. Give me a thumbs up if you can hear me.
There we go.
Okay, super. We are back on business. Okay, good. So then we go on the distal fedlock, P1 right here. You're going to find some fragments over here. And this is the lateral oblique. That means this another view for another name for this view is DLPMO, right? So this is the P1. You go drawing over the border P1, distal P1, and you're gonna come up and you're gonna read this whole P1. Then you go to P2, and you are going to go on the checklist that I gave you to make sure that you have absolutely every structure covered. Very important. Now this is the medial oblique. It's the exact same thing. And sometimes the only way to know is because of the marker. The marker should always be on the lateral side. All right, so here the same thing. We go on distal MC3, we go down, we go to the condyle. Race horses will get a lot of disease right here in the palmar condyle. They will get sclerosis on this area. Sometimes they get little fragments. Then we're gonna go up MC3, checking for the splint. Don't forget the splint. A lot of people forget the splint bone over here. Then we got the medial sesamoid, looking for sesamoiditis, fragment of fractures. And we go down P1 all the way to the pastern. Now, remember, distal to the pastern is the coffin joint. Sometimes you're gonna see some coffin joint areas, important to see. Now, here's the carpus. Back to the checklist. You're gonna go to the checklist that I just gave you, and you're gonna make sure that every structure that you see in the checklist is in the carpus. On the medial oblique, right here, this is the medial side, palmaro-medial side, and this is the dorsolateral side. Therefore, you're gonna go to the radius, go down to the radius, and then palmar radius, up. Sometimes here around this area, you can start finding osteochondromas, very important. They can be painful. Then right here, we're gonna look for the border of the distal intermediate carpal bone. And then right here, we're gonna go C3. And if we change the contrast a little bit, you can see the lateral splint bone right here. That's the lateral splint bone. You guys see it? And then this is the medial splint bone. You know this is the medial splint bone because it has full articulation with the medial splint bone. And then you're gonna see fragments in all these areas on these racehorses. And one of the reference papers that I gave you will give you talk about palmar fragments of the carpus. Now on the lateral oblique of the carpus, right here, obviously, again, you're gonna go radius. Right here, you're gonna find a lot of spurs. You're gonna read the whole X-ray. Then you're going to come here, accessory carpal bone, ulnar carpal bone. Then right here is the lateral aspect. That is what the lateral splint bone, the fourth metacarpal. Right here, you're gonna see some mineralization sometimes, which are okay. Right here is gonna be fourth carpal bone, third carpal bone, and then now, if we change the contrast on the distal side over here, we're gonna see the second metacarpus. You guys see it? Yes, second metacarpus and the second carpal bone right here. Fragments in this area are very common. Fragment and spurs in the distal radiocarpal bone, and they carry a guarded prognosis. In the flex lateral, again, make sure we read all the radiograph from top to bottom, from right to left or left to right, whichever you prefer. But right around this area, sometimes you're gonna see some osteochondromas sneaking in. It's very important. And right around this area on the accessory carpal bone, you're gonna see some fragments, which are important if they are articular, all right? So the distal radius coming in. Now, this is the intermediate carpal bone because it rises high on the flex. And this is gonna be the radiocarpal bone because it drops like a rock. Radiocarpal bone drops, all right? Now, over here is obviously the metacarpus with the splint bone superimposed upon each other. Don't worry right now which one is which because you're gonna find it in the obliques. And right here the same, you're gonna see the third carpal bone. Sometimes you're gonna see slap fractures right here on the third carpal bone. Now there's a flex lateral. A good flex lateral, you can see from side to side, just like in this one, you can see from one side all the way to the other. That's the cartilage, obviously. So again, always read the whole bone. Distal metacarpus. This is the proximal sagittal ridge. This is the mid-sagittal ridge. And this is the sagittal ridge. On the palmar side, you can see fragments anywhere around the sagittal ridge. We have the sesamoids. The sesamoids, we're looking for the apex, the body, or the distal sesamoids, and we are going to see fragments and spurs right here, and fragments and spurs right here. These ones carry a slightly conservative prognosis. This is P1, all the way from the top, all the way to the bottom. Make sure we read all the radiographs. Sometimes you're going to see fragments here as well. Now this is the skyline of the carpus, and here is the third carpal bone. Remember, on the lateral side right here, you're going to have the intermediate facet, and this is the radial facet. So there's articulation here with the radial carpal bone. There's a lot of places, a lot of times you're going to have sclerosis here, slab fractures. This is the intermediate facet. You seldom see problems with this just because the way the knee articulates, or the once in a while we'll see a little bit of sclerosis. Now this is a hind fetlock. The hind fetlock is slightly different than the front fetlock. After a while, you're going to notice some subtle differences in the sesamoid shape, and you're going to notice some subtle differences in the cannon bone right here. And that's a way you can tell it's a hind fetlock versus a front fetlock. Remember always to read the spleen bone. Right here, same thing, sagittal ridge. See, reading radiograph is super easy because it's all the same. You always start at the top, you go from the bottom, you go cannon bone, proximal sagittal ridge, mid sagittal ridge, palmar sagittal ridge. Then you take the sesamoid, border of the sesamoid, and then you take P1 all the way down to P2. Palmar P1, done. Easy peasy Japanesey. Same thing over here on the other fetlock. Again, same thing. Now, an advice that I give you guys is to make sure that you don't get bored while you're reading the next fetlock, because sometimes people get bored and they think it's all the same and they miss important chips. So read every radiograph separate, like if it's the very first x-ray that you read. So every radiograph, I do every time I read a full set of radiograph. I go cannon bone. This is the epicondyle, right? Epicondyle. Then I go on the condyle right here of the cannon bone. Then another condyle. Then I go up and I read the splint bone. Then I go on the sesamoid, articular surface of the sesamoid right here, apex of the sesamoid, abaxial surface of the sesamoid, base of the sesamoid. Every single one of these points that I have mentioned can get fragments, and it's very important to get them. Then again, apical sesamoid, going down to the base of the sesamoid and looking for fragments or spurs. P1, palmar P1, distal P1, condyle of P1, which you can get cyst over here. Ooh, what did I do? All right, condyle, distal condyle P1, both condyles, you can get cysts on both of them. And obviously you can get fractures. Now, the DP view of the fetlock, same thing again. MC3 all the way down. This is the condyle. This is the medial condyle. How do I know it's the medial condyle? Because the marker right here is always on the outside. So in this case, this marker is a dime. Medial condyle, sagittal ridge, where you're going to be seeing sometimes demineralization of the sagittal ridge. Then over here is going to be the lateral condyle. You have the epicondyle, where the collateral ligaments are going to be coursing through here. So important site of enthesiopathies. Then you're going to go up, all the way up. Now we go to the sesamoid, evaluate each sesamoid again in a new unit of time. Evaluate the sesamoid again in a new unit of time. Now notice here in this view that right here, there's a little bit of sclerosis, but that's not a sclerosis, that's just thicker part of the bone. The bone is way thicker because of the sagittal ridge. So sometimes you can think that this could be a cyst or this could be a cyst, but it's not a cyst and it's not a lucency. It's just because this part is thicker. Then same thing, P1 going down, P1 going down, boom, up. And in the pattern lucencies, which is one of the papers you will read, right here, sometimes you're gonna have a normal lucency, right? Just the way the anatomy of the bone is. Lucencies here are no good, very difficult to deal with. Lucencies here are more acceptable. Same thing, right hind fetlock, all the way down. Epicondyle, look, this horse has a little bit of remodeling over here. No big deal in this case. We're gonna go to the distal condyle, all the way up. Then we're gonna go sesamoid, apical, apex, abaxial surface, base, every time you read a radiograph. And when I started, I will mention it. I would talk to me in my head. Okay, this is the apex, this is the body, this is the base. That way I don't miss anything. Right here, and right now, by the way, you can just use your checklist if you're reading them. That way, every time you read them, you get what you get all the structures without missing one. P1, proximal P1, plantar P1. There's a lot of chips over here, as you can see in the cells, and these chips are not to worry. Okay, not to worry. Chips over here, a little bit more worrisome sometimes. Over here, not to worry at all. Palmar P1, plantar P1, you're going to see remodeling of the oblique sesamoidian ligaments right here. Not a huge deal either. Then you go down to the condyle, look at the condyles, and dorsal P1. P2, sometimes you see fragments here, and sometimes you'll see P3 over there. All right, this is a hock, which is a medial oblique of the hock. We start with the tibia, the same thing. You go down the checklist, tibia, dorsolateral tibia, distal intermediate reach of the tibia, then you go all the way up, plantar tibia, go up. Good, done with that bone, next bone. Lateral trochlear ridge, where there's a lot of OCDs. Then medial trochlear ridge, right here. Then you come to the sustentaculum thalli. The sustentaculum thalli could develop remodeling, fragments, etc. You go all the way down, great. Proximal intertarsal joint, which if you see spurs over here, they are significant. Distal intertarsal joint, where if you see spurs over here, are not super significant. We can deal with it. You evaluate the joint space in all these joints. Tarsometatarsal joint, where you're going to see spurs around here. This is the medial spleen bone. All right, and the second tarsal bone. And that is that view. Here we go. This is the DP view. This is the lateral side, and you do not need a marker to know that this is the lateral side because the calcaneus goes on the lateral side. Very important. The calcaneus always on the lateral side. Now, over here is the the fourth tarsal bone interacting with the fourth metatarsal bone. Right here is the suspensory origin. Very important to take a look at this. Now, the joint space, do not always evaluate it in these views. Do not always evaluate it joint space on the x-rays for the sales because that's not what we're looking for. If you're gonna look for joint space, you have to look at all the views, not just the DP view. A lot of people call this decreased joint space, but that's not enough evidence. You need to have more angles. Does that make sense? Very important because I see that a lot. People call decreased joint space, and you need all the other views to get that decreased joint space. Then on the medial side, we're still looking for, on the center over here, we're still looking for the distal intermediate reach of the tibia. And right here, obviously the medial malleolus, you're gonna see some fragments on the medial malleolus. And you can see enthesiopathies, like always in the collateral ligaments. The lateral view, same thing, tibia, look for the tibia, distal intermediate reach of the tibia, or dirt, like some people call it. Caudal, plantar part of the tibia, all the way up. We get the talus, then we get the sustentaculum thalli over here. Then we get the talocalcaneal joint, not a fracture, talocalcaneal joint. Very seldom I see problems with this joint, and if I've ever seen a problem with the joint, has been diagnosed on an MRI, more so than a radiograph. Now here, the two trochlear ridges should be superimposed upon each other, ideally. Sometimes you're going to see small fragments here from the medial trochlear ridge. Small OCD fragments are perfectly normal, nothing wrong with that. Proximal intertarsal joint, distal intertarsal joint, tarsal metatarsal joint, lateral spleen bone. All right, here we go. Stifle. Stifle has always read the femur, lateral trochlear ridge, which can get OCD, proximal lateral, medial trochlear ridge, I apologize. Medial trochlear ridge, which can get OCDs and lucencies, mid trochlear ridge, distal trochlear ridge. Now the lateral trochlear ridge, we're going right here. Same thing, proximal, medial, mid, distal. Patella, you can get spurs right here in the patella. Tibial tuberosity line, growth plate, perfectly normal. Then over here we have the proximal tibia. That's all you're gonna evaluate on this view. Then in this view, in the racehorse, you're gonna see a lot of changes on the medial femoral condyle. And please do not forget the lateral femoral condyle. More commonly, medial femoral condyle lucencies, cyst, flattening. A lot of flattenings are normal, and a lot of this, you're gonna see a lot of cysts, which are relatively easily fixed with a screw or injections. Proximal tibia, you can see spurs over here. If you look carefully over here, you're gonna see a shade, black shade, that's the meniscus. That's the shade of the meniscus. Then here you have the tibial eminence, which we evaluate better on the corocranial view. And here's the lateral trochlear ridge, which is very common. You're going to see very commonly OCD fragments. Now, on the corocranial view, right here, you're going to see a lot of cysts, especially at the sales. So be in the lookout for it. Spurs in the proximal tibia, medial femoral condyle. You follow the condyle, go the way to the lateral femoral condyle, and you're going to see these irregularities. That's normal. This is normal because these horses, a lot of times this lateral femoral condyle is just has irregular shapes. So you're going to see these little lucencies and sclerosis, which is not a big deal. Then here you're going to see the fibula, and obviously the lateral femorotibial joint with the meniscus highlighted. This line is the tibial tuberosity line. This is the other stifle. So you do the same thing. You follow lateral femoral condyle, medial femoral condyle, lateral femoral condyle, proximal lateral tibia, tibial eminence, right? Medial eminence, lateral, where the cruciates attached. You go down. Sometimes you see a cyst over here, not to be confused with just benign lucencies, okay? Then you're gonna come all the way over here on the medial tibia. Boom, you're done with the stifle. Now this is a real time. I go femur, medial femoral condyle, lateral femoral condyle, lateral trochlear ridge, and then I go on the proximal tibia, medial tibia. I'm done with that view. Medial femoral trochlear ridge, lateral trochlear ridge, patella, femur, caudal femur, proximal tibia, eminence, done with that view. Now the hock, let's practice. Distal, go ahead all the way to tibia, intermediate reach of the tibia, caudal tibia, done. Calcaneus, all the way around the calcaneus, done. Sustentaculum tali, done. Talocalcaneal joint, done. Proximal intertarsal joint, distal intertarsal joint, tarsal metatarsal joint, MT3, the two trochlear ridges, done. That's a little bit more of how you do it in real time. And right here, we're gonna go to, again, now the other side of the horse. I don't think we need to go to the other side of the horse, right? You got that? We can go to the larynx. Let's go see some scopes. Doctor, good? Ready to see some scopes? All right, so now let's go and see some scopes. So at Racehorse, we're gonna evaluate scopes. We're gonna be evaluating the larynx, and you're gonna be evaluating the pharynx as well, and you're gonna evaluate the arytenoid cartilages. So let me pause it. You lost me? ¿Me escucha? Okay, so right here is the epiglottis, and think that every single structure in this scope can be affected, can be damaged, all right? So you can have problems with the epiglottis, you can have problems with the arytenoids, you can have problem with the vocal cords right here, you can have problem with the trachea, you can have problem with the arioepiglottic folds, and you can have problem with the pharynx. So at the beginning, I always tell students, just when you look through the scope, focus on looking at the anatomy and then look for pathology. So first I want you to focus on the anatomy, then we look at the pathology. Look at this guy, how he's opening very wide and he's functioning very well. So this guy is opening symmetrical. This is a grade 1 scope. Very synchronous. So we grade the larynx. There's no standard of grading larynx, and that's usually a little bit of a problem. However, something that is known is that a grade 1 is a good throat with good synchrony. Epiglottis is on the right place and normal. That's what grade 1 means. Then after that, there are two different scales. There's one that's the new scale that is grade 1.1, 1.2. Doctor, what's the new scale? How does it go? It's not commonly used in practice,
grade
but
1, grade 2, 1, 2, 2.
Okay.
And grade 3.
So grade 1, then grade 2, 1. Which one is the 2, 1?
The 2, 1 is opening of the arytenoids, in which they're symmetrical but asynchronous.
So 2, 1 is symmetrical but asynchronous.
Asynchronous, and when it abducts, abduction is maintained
And maintain abduction. So that's grade 2, 1. And what's grade 2, 2?
Grade 2, 2 is asynchronous and asymmetric.
Okay, grade 2, 2, asynchronous and asymmetric.
Yeah, but abduction is achieved.
And abduction is achieved.
And maintained.
Okay, so grade 2, 2 is what we call in the sales a grade 2B or a 2A.
They call it grade 2, 2 or 2B.
Okay.
Yeah, well, 2, because between 2A and 2B is it's very subjective.
Correct. So in the new scale, the new scale calls grade 2, 1 and 2, 2, what we call in the sales 2A. And what's the next one?
The main difference is between grade 2, 2 or 2B and grade 3, in which grade 3 is there's asymmetry and asynchrony, just as grade 2B, and there's abduction that is achieved, but it's not maintained.
Okay, so in the grade 3,
and then the left one falls.
Okay, so in the grade 3, the abduction is, in the new scale, the grade 3 abduction is not maintained. So just for you guys to know, in OBS, at the thoroughbred sales in OBS, to pass a mid condition of sales, it can be asymmetrical and it can be slow, but it needs to maintain for a couple seconds to pass. Now, a Keeneland, if you hold the nose of the horse and you get one quick abduction, it meets condition of sales. So it's very important to know where you are at, because at OBS versus Keeneland, they have different requirements. So in the old scale, which is most common that we use at the At the sales, a grade 2B meets condition of sales at both. But in OBS, in the new scale, a grade 3 does not make condition of sales. You see how it gets all confusing versus grade 1, grade 2, grade 3. So what we've done at the sales, and it's like an unspoken, unwritten rule, is that we still use the old scale. And if we talk about grade 1, it's nice synchronous, good. Grade 2A is asynchronous, good. Grade 2B, and we'll see a grade 2B over here. And then we talk about the size of the larynx. And when you scope a whole lot of them, you're going to see that some of them are smaller and some of them are bigger. And then the epiglottis as well. So this is a good epiglottis. Now look at the anatomy of this larynx. It's a little bit different. It's a little smaller, but still opens very nice. It has an epiglottis that is robust. Right? It's just not as big of a throat as the other one. But overall, very good throat. Meets condition of sales, all good. Some clients and some buyers do not like small throats. Now you see what's wrong on this scope? When we started, there is dorsal displacement of the soft palate. And here I'm trying to replace it. And I'm moving the scope around to see if I can replace it. It's continued to be displaced. You see the border of the palate continues to be displaced. So this is dorsal displacement of the soft palate with good function of the arytenoids. And these guys are the ones that end up getting a Llewellyn procedure or a tie forward. Llewellyn procedure is what they call in the track like the myectomy. So it continues to be displaced, and I try to do anything possible to replace it. And let's see, I couldn't replace it. So diagnosed dorsal displacement of the soft palate. Now, coming up, what's coming up? Come on. All right. So now, look at this one. Good function, okay function. You see how one arytenoid is moving faster than the other? But now, look at something tricky. Remember I told you, always look at the vocal cords. Look right here in the vocal cords. You're going to see some points. So this horse has the beginning of chondritis, or how we call it, this particular one, we call it kissing lesions in the tract. You guys see it right here? You see it right here. You're gonna see a lot of these before they go to the sales because of traumatic origin, contamination, sometimes fungal in the farm. So this is the reason that we scope horses before they go to the sale, because if they're at this point, we can treat them. We do antibiotics, we do throat sprays, nebulizations, and we can treat them. Now, eventually, you're going to see some of them that are not treatable. So this is the same thing. You can see here, this one is starting to get thick. You can see a little bit more reddish. So this one is starting to develop a more profound chondritis. And this is real time. So this is what you're going to see when you're in the scope. You're going to see a lot of mucus. You're going to see sometimes in the books they present you beautiful pictures, but that's not always the case. Sometimes you have a second or 2 seconds just to look at these scopes. So right here, chondritis. So how do we treat this? Antibiotics, Baytril, doxycycline, throat spray, and it looks they clear up most of the time. And some of them are really bad. We also been doing rifampin. So here's another one, just to get you a view of a good one before we go to a more pathological one. So what do you think? What size? Good size? Poor size? Good size. Epiglottis. Good epiglottis. No chondritis. So it's a good throat. This is how we want these throats to look at the track. Okay, here's another one. Now, look at the difference of the shape of the epiglottis. You see that this one is pointy. So old school, you're gonna get, when you talk to like the 60-year-old guys and the 70-year-old vets, they're going to talk about this pointy epiglottis, and a lot of them don't like them, and they tell the owners that they can display. They tell, I don't see any, I haven't seen any evidence that this is a significantly inferior epiglottis. At this point, I just cannot advise against buying this one. Now, the size, if a client tells me that he only wants a large size, I probably would not be recommending this throat. However, there's no scientific evidence whatsoever that it matters, okay? Nothing. This is just, I'm telling you what they talk at the sales, the things that they don't teach that you kind of pick up with the years of being at the sales. Now, very important to take a look at the arytenoids right here to make sure that they are on the same place, okay? Sometimes you can have asymmetrical placement, and those tend up to have a poor prognosis. I haven't seen many of them, maybe 2. Look at this size, tiny throat, but good epiglottis. And I'm gonna cover his nose over here. You can see it because the pharynx almost collapsed, but you see it's quite asymmetrical, and I don't see this one moving a whole lot. You see, depending what cell you go, this horse, it just move. So it will make condition of cells, but it's what we call the cells a 2B. It's quite slow, quite asymmetrical, and this one doesn't fully come up and stay there. So that one's a tricky. Very careful when buying these horses, because they can paralyze. Even though there's a paper by Rolf Emberson and peers from Kentucky that said that it did not affect earnings, but I'm not sure about that. Look at this throat. This one is, what's the diagnosis? Displacement of the soft palate. And what else? Trick question. Look, there's a little bit of food right here. So this one, there's a little bit of food over there. So sometimes these horses develop quite of an infection because of that. Food goes up there. So I displace and replace. And a lot of clients don't want any displacement, which is a little unfair for the horse, because any horse can displace. It's normal for the horse to displace once in a while. We just don't want him to stay displaced, or to do a lot of displacement, or to displace while he's running. But it's normal to displace a little bit once in a while. It happens. It's common. Okay, this horse has a little bit of mucus coming from the dorsal, from the roof of the pharynx. I had a pointy epiglottis, but look how interesting the epiglottis sits higher a little bit higher on the palate. That was the only tricky thing that I saw on this horse. I didn't know what to make out of it. So here's another example. Good size, good function, real time. This is what you're gonna see when you're in the scope. It's gonna be moving a lot, and you can get a good view, you can get a bad view. It just goes. Sometimes they're not as easy. And the reason that's why I put it in these videos, because I don't want to just give you easy videos. Good. So because I'm running a little bit out of time, I am going to jump to some interesting pathologies. So you already saw slow, you already saw chondritis, and I want to show you. You see, this is the chondritis later. This is the chondritis that didn't get treated. See how it starts to get bigger. Hopefully it clears up soon, because I'm gonna touch the scope with the pharynx, and right here you can see the bigger area of chondritis. These horses, by the way, when they are this bad right here, we do rifampin, Batro, and we do hyperbaric chamber as well. And we have been able to clear them up very well. Now, when they get to this spot, these horses do horrible. You guys can see it all the way here. These horses do very poorly. We haven't had good luck with these horses. We have done everything that we can think, from different antibiotics to hyperbaric chamber, nebulizations, and we have had very luck. So the best thing to do is to try to take them out surgically, and they still do poorly after that. Right there. This horse went racing, but it was suspected to be a stakes horse and ended up racing on claiming horses. So she did okay. She won some races. She just didn't perform as expected. And then ultimately, some trainers just don't see it and don't catch it, and it gets worse and worse and worse, and it actually ends up sometimes collapsing. We have seen that. We have seen that as well, like this one. So this is a real scope, real time. This is a chondritis that did not get caught on time, and this also was breathing a little bit. We ended up doing a trach. Like, look at this tiny little air slit. All right, and that is the essence of the sales thoroughbred horse. Any questions? Oh, by the way, wait a minute. So there are some places where you guys can obviously go and read about. Let me see if I can introduce you to them. Oh, Dr. D'Angel, because you didn't see them at the beginning. So for pathologies, right here, there's the common pathologies of the Stifle. It's called equinearthritis.info/Stifle. You can share this with your students.
Super.
And then we have one. This one has the medial femoral condyle cyst, OCDs, most of the things that you can find in the Stifle. The flattening. Oh, this is a cool one. We didn't talk about calcinosis circumscripta. OCDs on the medial trochlear ridge.
I think the presentation stopped.
Oh, wait a minute. How about now? Can you see it? Good. So, do you see now? Good. So calcinosis circumscripta, nasty OCD over here. All right, so then you can see the ones on the fedlock, and the common pathologies that we see are sesamoiditis, like this one. We see P1 chips. We see proximal sagittal ridge. We see more P1 chips. We see lucencies in the femoral, in the condyles. Remember, this is why we read the whole X-ray. We go here, condyle, sagittal ridge, condyle. Oops, there's a cyst over here. And then we have arthritis. And many more. This is one of the ones that I was telling you about, the lucency in the distal P1. These lucencies are not necessarily cyst. They could be normal findings. Then the same thing for the hock. You can find OCDs in the distal intermediate ridge of the tibia. You can find arthritis. You can find more arthritis in the tarsometatarsal joint. Then you can find OCDs on the malleolus. then this is a horse with decreased joint space for sure. So you can see remodeling, you can see decreased joint space in multiple areas. This is a horse with a fracture of the third tarsal bone. And that's about all I have for you right now because I ran out of time. But you can always go to these web pages and obviously get a good view. And when Dr. Eric helps me out, we'll finish the carpus and the foot. Good deal. Good. Hope you learned something. Questions? You guys have a great day. And if you need me, just give me a call.